thing before Dr. Acharya delivers his oration. I want to tell one thing in front of all of you, because I take all of you to be my family members. Few days back, when first time this IFSM state was had, yesterday night I have seen a dream. What is the dream? Dr. Acharya has seen a dream. Who is a practical man, who is a man of practice, who is a practical man, has seen a dream. So let me know what is the dream. Then he told, sir, I have seen that you have come to attend the conference and you have come with a new car. Yeah. And that he told the color of the car, that one white colored car, and you are just coming out of the car, I was there. So, see this psychological attachment and the relationship.
Coincidence.
So dreams should come true.
It has also come true. Because if you have been contacted by this last time, my new car would have been purchased. Because the delivery time was 3 months, so it was not coming within that. The conference was shifted, so I got this car and I have come with that new car. So, this is psychological attachment, psychological relationship.
First car you are going to our department.
Yes, at that time, one of our PG students was there, Devasis Gavarda. He told one day that, sir, ଆପଣ କାହିଁକି ସାଇକେଲ ଚଢ଼ିକି ଆସୁଛନ୍ତି ଆଜି
ସାର୍ ମତେ ଭୁଲି ଗଲେ
ସାର୍ କାହିଁକି କହୁଛନ୍ତି ଆଜି ଯିବା ମୁଁ କହିଲି ନାଇଁ ରେ ବାପା ଆଜି ରାହୁବେଳା ଅଛି ତ ସେଠୁ କେହି ଆଉ ଶୁଣିବାକୁ ପ୍ରସ୍ତୁତ ନାହାନ୍ତି ଉଠିଲେ ଯାଇକି ମୋ ପାଖରେ ପହଞ୍ଚିଲେ ମ୍ୟାଡାମଙ୍କୁ କହିଲେ ମ୍ୟାଡାମ 500 ଟଙ୍କା ଦିଅନ୍ତୁ ସେଠୁ କଣ 500 ଟଙ୍କା ତମେ କଣ କରିବ ନା ଆମେ ଯିବୁ ସମ୍ବଲପୁର ସମ୍ବଲପୁର କଣ କରିବାକୁ ଯିବ ତମେ ମୋ ପାଖରୁ ନେଇ 500 ଟଙ୍କା ନା ମ୍ୟାଡାମ ଦେଇ ପକାନ୍ତୁ ତ ତାପରେ ପଛେ ଜାଣିଛୁ କଣ ପାଇଁ ଦେବେ ଆପଣ 500 ଟଙ୍କା ବେବତା ଧରିଲା 500 ଟଙ୍କା ଚାଲିଲା କଣ ନା ବୁକ୍ କରିବ କାର ଯାଇକି ସେ ଲାଗି ପାତିକି ଆଗ ଦିନ ଭିତରେ ସେ କାର ଆଣିକି ସେଇ ବି ତାହାରି ପଟେ ସେତେବେଳେ କାର ଆସିଲା ନହେଲେ ହୁଏତ ଆଜି ପର୍ଯ୍ୟନ୍ତ ବି ସେ ସାଇକେଲ ଚଢୁଥାନ୍ତି
ନାଇଁ ସାର୍ ଆସିଗଲା ତ
So I don't want to take much of your time. So my first word that it's a family. So in this family, we are so much attached with one another. In that respect, now today he is retired, but he is there with our department, and you will be surprised that he was a good practitioner. In Bargarh, in Raurkela, he was having a very good practice. His wife also is a pathologist. So they could have just went with this practice and could have earned much of money. They could have made much of money. But see, the attachment was teaching. He left that and he came. Though he became junior to many of his juniors, still he joined this noble profession of teaching. That will be community medicine. So, sir, community medicine department is really thankful to you.
Sir. Thank you. Good afternoon to you all. Wow, the time is now mine. My limitation is that I usually very poor in keeping to time. I usually expand. 1 minute talk becomes sometimes 15 minutes, half an hour. Please bear with me. If I extend the time, I request Dr. Giri and Dr. Durga to not to throttle my neck. If it becomes a cord set, finish before time, wow, you have got a chance to flee. So I hope I will try to stick to the time limit. I think it's half an hour, sir. Half an hour now? So, R.G. Panigrahi, Oration. I have attended many in past. What I had seen is it is actually a rhetoric speech. It's written previously, read over the sessions, and this speech is usually circulated among the audience. In that sense, I'm not an orator particularly, I'm a teacher. You are all my students. Your teachers are also my student. Many of your teachers are my student. So Sadhu Panda is my student, Smita is my student, Lisa is my student. So I am your teacher's teacher. Okay. I am privileged to be a speaker of R.G. Panigrahi Oration Award, though I am not an orator. Anyway, thanks to the organizers, particularly Smita. He one day phoned me and said, "Sir, you don't have to say no to what I say." I could smell it. Okay, they are going to throttle my throat sometimes regarding this thing. But I am really, what should I say? Hats up to them for choosing such a nice theme. The theme is need of the hour. We have been teaching to the undergraduates primary healthcare. We ask them what are the principles of primary healthcare, what are the dimensions to one and say alternate students in the undergraduate. If you look into the 4 principles of primary healthcare, the number 1, you look into the path textbook, number 1 is equitable distribution. And they have rightly chosen the scheme or to be presented in the conference. And the equity, regarding equity, unequal health has led to many health problems. This has been envisaged particularly during past pandemic. And much of the issues regarding inequality has been answered or addressed rather in the last pandemic. So I'm thankful to speak on R.G. Panigrahi Oration Award. So it's a written speech, and to that most of the slides I will try to add something of my own. Health inequality, everything is defined. Okay? Health inequality also is this definition is not recent. It has been made since long by WHO. Say the World Health Organization defines inequality in health as difference in the health between health means health status between people of groups of people within the community and between the intra-community and extra-community, interstate, inter-community and extra-community. So the stakeholders are not related to a particular community, in between different communities inside the state, and also in between the states, and also in between the country. So long as if you don't try to cap the inequality between all of them, ultimately the health status of the community as a whole, of the state as a whole, of the country as a whole cannot be achieved. Yes, types of inequalities they have tried to typify it. There are many, but if you think of your own in terms of inequality also, if you analyze them, they will be put into one of the 4. Geographical, you all know there is inequality. That is the reason, because there is difference in the inequality in the health status beyond the geographical barriers. Ultimately, people are suffering. Gender, much has been told. Each one of these is the geographical barrier inequality, gender barrier inequality, information barrier inequality. I am informed much more than what the rural people are not. Many times I have to give speeches in the rural area. They refined, the information variant is so much, they do not know much about them. So that needs to be answered, okay, closed, the information, and of course we know social barrier. Okay. These four major types, if you are all public health specialists, if you think in isolation, you can find out many types of inequality also, but ultimately they will be fitted to one of these dimensions, many dimensions of inequality. Few of them are socio-economic status. Of course, difference in the socio-economic status ultimately leads to inequality. Analysis is much more, I am not going to expand it. But there is one dimension, major dimension rather. Then educational difference, status in the educational level of the people, intra and extra community. Then place of residence, rural and urban difference will lead to the always we have been taking 70% of the health say infrastructure is being spent on 20 or 30% of the urban people and the reverse 20% of the say the health infrastructure health expenditure is spent. Much has been told. This has been told since long. Then occupational difference ultimately leads to again a lot of examples are there. Occupational difference, gender, I repeat, gender difference is always there, and of course religious. Different religions they have status. Even today also, if you ask, if you inquire, if you convince certain people of certain religions, they refuse to take the vaccine against COVID. I don't want to tell the religion. Yes, for our research, because in the perspective I say, it's Odisha perspective we are going to discuss the health inequality. We must know where our state Odisha is. It is the 8th largest state in fact in terms of area, 11th largest by population. Odisha has been placed dismal when it came out. We all became very much dismayed, sorry. 14th among the 19th large states by Niti Aayog. It's not the place forum to discuss or to criticize Niti Aayog. Anyway, they did something, they put Odisha in the 14th position. And that's one of the reasons. There is inequality, that's why we are close to 14th. Okay? We are not placed first, second, third, something like that. Health inequality exists in Odisha again. Health inequality. Why this inequality? The inequality is because of the indifference, the difference in the health indicator achievement in terms of health indicators. The mathematics, arithmetics they do in terms of calculating the health indicators. We are a lot of difference. Okay, that's why Odisha has become. So to measure this, this is the most important slide. Sustainable Development Goal. Many years we have been teaching Millennium Development Goal, then it was converted to Sustainable Development Goal in the year 2015. Okay. They did some homework, they did some work in terms of say certain indicators, maternal mortality, infant mortality, education, fertility in terms of anemia, and we corrected certain points, marks. And ultimately, when we added them up, it came within 0 to 100. And accordingly, they have divided into 4 categories. Okay, one is the average, 0 to 49. Front runner, performer 50 to 65. Front runner 65 to 99, and achiever 100%. 100% achievement is humanly not possible to achieve. It's a goal, just like health for all by 2080. By the end of 2080, suddenly you will find that all people are healthy. It's not possible, but it's a goal. We should all try, Odisha should try, other states should also try to reach to that goal. And by that only, by the purpose of telling this slide, presenting this slide is that if you don't try say gold, you cannot win say bronze. Your focus is gold always. So that at least you can say get silver or bronze, okay? Like that. So accordingly, they have found sustainable level some 13, 17 indicators are there. They calculate all those things and they find Orissa to get 67% mark. That's good. 67. And that's why they put 67. That means we are front runner. I still have the hope of getting, I may be bronze now, but I will be getting silver or gold someday. And we will achieve. Okay? I am very optimistic on that. We have subsequent slides will be fine. We can see how we are achieving. Good things are coming. Always hope for the best. So we are front runner, at least not back runner. We are front runner, and we will ultimately will get the gold. Okay. This is a complicated one, but just I will try to. Orissa, they have put, I tried to say deliberately exclude upper states and lower states. The thing of the purpose of presenting this table is that these are the indicators. Say, these are the indicators. Maternal mortality ratio, under 5 mortality, percentage of children in the age group of 9 to 11 months, fully immunized. This is very, very important, fully immunized. And there's a total case notification in terms of common coverage. So in this SDG, ମାଦଳା କାଞ୍ଜି କରିଦେଇଛନ୍ତି ଭାଇ କଣ ନାହିଁ ସେଥିରେ ମୁଣ୍ଡ ପାଗଳ ହେଇଯିବ 17ଟା ଇଣ୍ଡିକେଟର ବଢି ବଢି ବିରକ୍ତ ଲାଗିବ but these are the important ones. But some criticism sometimes they are why suddenly they excluded this IMR. Immunization is not giving importance also, but anyway. Okay, so HIV incidence, then suicide, it's non-communicable ones. In SDG as against MDG, okay, the non-communicable diseases are also taken into consideration. Suicide, women's violence, accidents, okay, other non-communicable diseases. So all these things, anyway, Orissa is 19. In terms of the indicators, say maternal mortality, subsequently I will show you, say as on say 150, under 5, 44. Let me not bore you giving you the statistics or numbers, okay? Play of numbers, boring. Again, very exhaustive one. Yes, target. This slide just shows the target. We must have a target. Okay? Then only we can reach the goal. Goal kono target kono. Sabu bade pacharo pila mane. गोलटा देवा टार्गेटा करा हो कि पुस्तक मारे गोल हवा बसंत कहीं बसंत अच्छी पुस्तक मारे गोल हवा गोल हवा okay you must fix some targets too. So that's why this is just the target they kept. I need not tell the targets here, and the justification of the target, exhaustive description again I don't want to read it all over. It's not a reading class. Okay? It's an oration versus speaking. Okay? Deliberation. So anyway, anxious indicators. What are the indicators they have taken? Yes, this is the slide exactly I wanted. Areas where Orissa is lagging behind. What are those? You just see MMR, CDR, O. IMR is there, bit below. Okay. So MMR 150 is against the target of 113. So we're lagging. 113 is the target as against 100. You see, one thing here, public people are there. These statistics change frequently. But that's why I always say, so for the statistics is concerned, okay, you just always come, so what is that called? What is the meaning of say surveillance, definition of surveillance? Bringing out collect the data and collate the data. Collate. Both the collate meaning mothe jana nathila. Plot for comparison. These data are in fact helpful to us. It brings an impetus to our brain to compare. Okay. So as on today, 150, 113 is the national figure. Crude death rate 7.1. हजार के गोटे लोग एटे बेसी मरची हो पृथ्वीटा उल्टी होला बाकी यार 6 मरछन हमर एटे 7 मरछन कोनटे हे गला. It's a target. Okay, then this is very, very important. OP, out of pocket. But Orissa, being a poor state, many of the people are beyond the poverty line. We are poor, in fact, we have been, say, visualized as a poor state in the national figure. Here, people, they need to spend more than what in all India average each. Yes, many things are done now to reduce the out-of-pocket expenditure. Out-of-pocket expenditure is itself a seminar classes. Many times we have had in our departments also. Out-of-pocket expenditure, important one. Anemia. The poor part of the anemia, 28.5, as I can see, 25, but the thing is that most of the 99% I can say are nutritional. Again, why nutritional deficiency? Another class. Anemia itself, 2 or 3 classes. Iron itself are 2 classes. So, but the thing is that I just want to tell one thing. Anemia and most of the things are nutritional, and our people either they do not know, or even if they do not, even if they know also, they do not practice it. So anemia, IMR. This is a specific indicator. Old park book text, they used to say comprehensive indicator and specific indicator. Haribandhu sir, Chali Varani, सबुबड़े पचारंती. Comprehensive indicator कौन? Specific indicator कौन? Comprehensive indicator, crude birth rate, crude death rate. Specific indicator कौन? IMR, and he will be happy if you answer age specific. The other day I was asking, telling some PG students, I said age specific, death rate specific. So IMR is a specific indicator. How come the SDG? I should not try to find the deficiency, but IMR has not been addressed much in the sustainable development goals. Probably they have included it to be discussed under the heading of under 5 mortality rate. Anyway, okay, anemia. 64%. Again, the same thing, either nutritional or pregnancy related or menstrual cycle related. Okay. Few things which can be corrected very nicely by a simple endeavor taken by policymakers, stakeholders, most important, doctors and public health specialists. Yes, what is doesn't have lag always, performing better. Okay. Under 5 mortality rate, 41.1, 41.9 nationally. Similarly, stunted children, 31 as I just Dhadiacha, 31, 35. Wasted, 18 and 19. Underweight, institutional birth, really I am happy. 92, to the best of my information, I think it's more than 92. It has reached probably 95, something like that. Anyway, it could be an older data, maybe. So, aspirational districts, if you just see, let me go back. Yes, aspirational 0 to 49. The same thing. Yeah, aspirational district. These 9 districts, 1, 2, 3, 4, 5, 6, 7, 8, 9 aspirational districts. The aspirational districts where in fact focus to be given more. They need, and in this you can find most of the districts are from KB, okay? From Western Oration. But how come I am sometimes astonished? Dhenkanal becomes one. Policy makers are there, public I request them to please analyze. Okay, why Dhenkanal? Aspirational districts. The thing is just one thing. Yes, government has started taking some policy to categorize them. Aspirational means you need to focus more on them. Okay. Then better performing districts, Kalahandi, Patak, Jagatsinghpur, Angul, Sonpur. In terms of again, somehow I'm not much invested. You cannot just take CDR, crude deficit to be for performing indicators. And what they have done it, and low performing 5 districts. These are the lower ones. Okay, I'm surprised. Sonpur being 7.5 and both is 10.3. They are contiguous districts. If you know physically, geographically, Odisha, Durga must be knowing. He has visited the entire Odisha. So difference, but difference is there. CDR some other indicators they would have taken, probably the districts would have changed. What I mean to say, if you change the indicators, okay, the SDG level will change, and ultimately the cause of inequality, because I have been given the responsibility of focus more on inequality. The inequality proportion inequality may change. It is changeable. Okay. Anyway, this is again Balangir, the neonatal mortality rate. I told you, neonatal mortality rate, it includes probably infant mortality rate. Manasi madam first anyway, 71 ରଖିଛନ୍ତି. Balangir, neonatal mortality rate, compared to say 850 neonatal deaths per last live birth in India, it is 1453. 853 ଥିବା ଅବସ୍ଥାରେ ଆମର ଅଛି 1458. Anyway, yes, I told you the things are changing. Okay. I may be wrong. This could be in the old data, but you see, बाकी गुड़ाक भी चेंज ହେଇଥିବ ନା, ସବୁ गुड़ाक ଯଦି ଚେଞ୍ଜ ହେଲା ତମ ପୋଜିସନଟା ତ ଚେଞ୍ଜ ହେବ ନାହିଁ. ଓକେ, ତମ କଥା କଣ ହେଲା, ତମେ କଣ ଗୋଟେ ସାଇଡ ଟକ୍ କରିଦେଲ. anyway, so performing 5 districts, and again this is an issue of home-based delivery. In these districts, 3.43. When I saw this picture, one institutional delivery above 90. Why come this 3.4, 3.5? No, it's like this. 97% institutional delivery ହେଇଗଲା. ତାପରେ ଯେତିକି home delivery ରହିଲା, the rest of the home delivery, we expect the home delivery to be conducted by skilled birth attendants at least, if not personnel, skilled birth attendants at least, and that is found to be only 3.4. That means skilled birth attendants are not called home. This is again a case. We should send the message, we should train them, we should speak them in such a manner that yes, you ask at least a skilled birth attendant if ANM is not able to come. Okay? Yes? Map of identified focus district for implementation of patient strategy for accelerated reduction in IMR. Yes, good thing. They have taken all means to identify the red colored districts. Okay? They need the accelerated reduction required in this. So what do you want to say? Why did I put this slide here? Again, why this white, red, yellow, all these things? Again, this leads to inequality, health inequality. Jodi no thanta, tahele imiti pade. So all over red and all over white you will have. Okay? Yes? Something on his infrastructure. Minister have already left. Anyway, his concern more. Total number of cases, some figure 1,305. Yes, total bed strength only 1,026. Indoor beds are available only in 13% or 14% of the people. In Odisha, 36,000 hospital beds are available, and out of them, 70% are public and 30% are private. Yes, the requirement, just see, WHO says, according to WHO calculation, 1,060,000 beds are required.
1,60,000.
केबे हवा दी कौन से कहते दिमाण घियो जे राधा पहाड़ी नाचिबो. So, and 51% of the referral beds, according to NAB, National Accreditation Board of Hospitals, they are in 51% of these types of bed are available in 4 districts. Again, inequality. Inequality of this. Yes, health worker strength 9.6 per 10,000 as it is as on today, and recommended is 23 health workers per 10,000. It needs to be increased 3 times, almost 2.5 times. Doctor population ratio 1 per 2,000, but targeting 1 per 1,000, just half. Okay, so KVK plus districts and non-KVK plus districts, there is diversity. We always talk of inequality. We always, and regions are there. They have identified certain regions. Okay? So poor people in these areas are poor socioeconomic status, more tribal and SC populations, lower health indicators. Yes, health indicators are low. That's why there is inequality, and these there is inequality. Health indicators. That is say vice versa. Okay, and poor road connectivity, low literacy, more rural poverty, dense terrain. The thing is that these are no doubt regions, but I personally say much has been done, and the policy makers, both at state and the center, they are doing a lot. They are trying a lot. Yes, no doubt, this cannot be achieved overnight, but a lot of things are going on to achieve. Particularly road connectivity. If you go into rural Orissa now, you will be happy. You will be not displaced because you may be displaced because you have not gone there 25 years back. I have gone there. Professor Giri has gone there. Rumapada to some extent must have gone there. And now when he goes there, now he can compare the green connectivity. In fact, it has improved. I don't deny it. Okay. So Johnny, how come we have become a good performer? This is because of hundreds of schemes of Janani Surakya Yojana, Janani Shishu Surakya, Karyakram, INC, RBSK, INAP, Nirame, Jan Ausudhi is a very good scheme. Okay. Telemedicine, the importance of telemedicine has been successfully done. We have all realized, particularly during last pandemic, telemedicine. They have done excellent work. PMJAY, Viju Swasthya Kalyan Yojana. A lot of things have been done. They have tried their best to reach to the community as close as possible. Okay, in terms of say monetary or monetarily health infrastructure, everything. Okay, so yes, I must say, Pilango Sovoli Parikari, what are the most important health problems of Odisha? We are not satisfied unless he says malaria. Malaria has come down. My wife is a pathologist. He says last 1 or 2 years he has not seen a single malaria parasite. In fact, in our laboratories also, they frequently now are saying that, say, malaria coming on, malaria. In fact, malaria coming on. Okay? So, Daman, particularly in terms of Orissa, Durga was the pioneer of this Daman project. Okay? Durgama Anjalari, malaria, Nirakarana. I am not going to discuss the details of Daman here, but we have achieved better and better knowledge healthcare. Because there is better and better knowledge healthcare, now the indicators have improved and Orissa has become good performer. Those inequality exists. Yes, this is the malaria map. I am tempted to show. Just see the death. It has come down from this. The red is PF. Total case, PF. Total case, PF. And the upper one is death. See? Just reduce. So it's not that we are always lagging behind. It's achieved also. Okay. This is another way of presentation how the trend of malaria in Orissa state has come down. So closing the gap. Access to healthcare facility is very, very important. If the access to the healthcare activity by the stakeholders, the community becomes less, inequality will be less. The region-specific planning, this is a very good thing. Nowadays, in all these, all the programs what I want also, decentralized participatory planning, they always say. So you cannot just decide in Delhi or Bhubaneswar what should be adopted for Koraput, Kalandi or Balangi. Okay? Decentralized, region-specific. The program in KVK disease, so far as malaria is concerned, was more. That's why Daman was particularly more, say, exhaustively faced over there. Infrastructure, one thing I would like to say here, infrastructure I think we have improved a lot. What is the infrastructure we have improved? In terms of buildings. There is no dearth of buildings, quality buildings also in terms of health institutions. But tak sambhalibo kiyo ho? Agar 25 medical college kar debe je doctor nahanti. So human resource. The policymakers in fact trying, okay, so to improve the human. Unless you improve the human resource, the infrastructure improvement only will not help. Okay. reduction out of pocket. I already told you, out of pocket expenditure. People do not have money to eat. What they will spend for money? Very good things are there for tuberculosis, for malaria. At least people are not going to spend thousands of rupees where to be spent in say tuberculosis. Now everything is free over there. Okay? In terms of diagnostics also, up to the extent CT, MRI or ultrasound also is becoming yes, this is important. The more you look into health and health inequality, you realize that a lot of what is not due to a particular disease. Yes, they दोस्तों नहीं भाई बीमारी को don't say curse the disease. Okay? Now what is this thing? It's really related to underlying societal issue such as poverty, inequality, lack of access to safe drinking water and housing. You see, safe drinking water, all these things are put in the sustainable development goals. Those are important. Not cholera, not diarrhea, not tuberculosis, not malaria. What are the things going actually causing to the person to acquire the disease? And that is again inequality becomes the main. Try to bridge, close the gap inequality. All those diseases will come. They will come down. Don't always try to hit the disease. Try to hit the regions for the wave of causes, regions causing disease. And lastly, this is most important. I should not have told all those things. This is the only slide important for the viewers. Okay? Something is going on there. Something is going on there. People are trying to enjoy it. People are trying to enjoy it. They are not able to enjoy it because there is a wall. Or people are not able to enjoy it because this fellow's height is less. Either way, break the wall, break the causes I have been discussing last all the time. Okay? Try to break or increase the level of height. Either way, and both are difficult. Both are very, very difficult. Increase the health status or normal status of the persons so that their height will be increased so that they can enjoy the event going on there in the stadium, or break the wall. Very, very difficult. Both are difficult. Still then, our policymakers, professionals, they are trying hard and they have achieved and they will achieve. I am very much hopeful. Coming 10 years, things may become very green and bright. So thank you very much. I did not take much of your time. I don't think Dr. Giri will throttle my throat. Anyway, thank you very much.